The equipment that I used for these injections I think was unique too. I happened upon a 27 gauge titanium needle. I found a manufacturer who made these, and they made them. You see here in the diagram that usually a 27 gauge needle, which is extremely thin, just a little bit thicker than a human hair. Usually they're very short because obviously the thinner the needle, the easier it is to bend. But titanium is a fairly stiff metal, and so I was able to find 27 gauge titanium needles that were 1.5 inches long. I needed that extra length because I didn't want to use a short needle and end up not being able to pierce into the interior of the knee, and then when I injected my mix, it wouldn't be going into the joint space, it would be going into the soft tissue outside the joint space. So we used a 27 gauge titanium. Now remember now, this was mostly for injection. I would never try to aspirate any fluid out of a knee with this thin needle, because the thinness of this needle and the thickness usually of the fluid that accumulates in the knee, you would not be able to pull it through it. I'd have to resort to the larger needle. By the way, most orthopedic surgeons and rheumatologists that I trained with, they use this larger needle. You know, when you use a larger needle like this, once you enter the joint space, there's a sudden release. And so it is very reinforcing to the doctor that he's in the proper area. And that's why I think they like these 18 gauge needles. But as for me, we did not use an 18 gauge needle because I knew these people were going to be coming back over and over and over and over. And if they had a very bad, painful experience with this 18 gauge needle, the likelihood that they would subject themselves to repeated injections was low. We also used 3 cc syringes instead of a 5 or a 20 cc syringe. And of course we use sterile single-use syringes, because the smaller syringe slowed down the velocity of the medicine exiting the needle. And as that medicine, which is a different pH from your body tissue, enters the joint space, if it enters it very quickly, that can be an additional pain, not to mention the additional pressure. And of course, everybody that we injected, we used sterile technique. And I don't mean just clean the skin off and then inject. I mean, we prepped the patient's knee and we wore sterile gloves and we injected the way I've told you. So the prepping we did was we always waited until the disinfectant dried. I don't know whether you realize it or not, but if you put a disinfectant on a wound and it's wet and then you inject through it, you've not achieved enough reduction in bacterial count on the skin surface. You actually have to wait for the disinfectant to dry. And so the few extra minutes that we waited, I think, was the reason why after almost 30 years of doing these injections, we never had one injection-associated infection. And that's unheard of, because you would expect an occasional infection, but we indeed did not. Now, the injection technique that we used was also somewhat different from many of the doctors in our area. The rheumatologists and orthopedic surgeons that trained me during my residency had me insert the needle from the side, under the kneecap here. And what I found was that in addition to using an 18 gauge needle, which is quite large, many times I ended up scraping the bottom of the kneecap here, and that's very uncomfortable for the patient, who's already hurting, by the way. So alternatively, what I reasoned out was a more anterior technique, and that is when you bend the knee at 90 degrees, I would usually have the patient sitting on the edge of the examining table. When they bend their knee at 90 degrees, the patella hugs the femur, and then two beautiful spaces on either side of the patellar tendon open up, and there's a beautiful entry into the joint space right here. And not very long, maybe just about an inch or 3/4 of an inch of tissue to pierce, and then the needle just slides nicely into the joint space where you can inject, and it's almost painless. You're using a 27 gauge needle, and you're you've got the joint wide open, and you're not bouncing off of any of the bony surfaces. You're going right into the joint. It is a split second, a little twinge of pain in order to seat the needle properly before you inject it. And I think this is another reason why we had such remarkably effective results with our knee injections. And many of my patients told me that it was the most painless knee injection that they'd ever had. And these are people that had had previously bad experiences with their knee injections. Now you might think, well, with the 3 different medications we were using and the wide variety of people that we saw, that there would be a lot of side effects with what we did. But in fact, here again, with almost 30 years of doing injections, we never had one serious side effect from the injection itself. And I always screen people for any previous reactions that they may have had to anything that we would be using, even to the skin prep solution that we used, which was generally alcohol or betadine. I would ask if they've had any allergic reactions, and we would pay close attention if there were infections. I'd never inject an infected knee. I think that's a bad idea. Even though the medicines that we're putting in are sterile, you're creating a conduit from outside to inside, and the knee's already infected. So I only drained infected knees. And if there was any large varicose vein in the region where I was going to do my injection, naturally I would avoid that. And what kind of results might you expect with this technique that I've just explained to you? Well, as I've said here unequivocally, okay, every single patient we ever use this technique with received significant relief and came back over and over and over and over for their injections. Now you may be wondering, how often can a patient receive these injections? And I'm going to disagree with the conventional teaching. If you read most manuals and articles on this, about 4 per year is what's recommended. But if you examine the background of how this number came about, and I found in orthopedic surgery, there's a lot of doctrines that are more tradition, and they don't really have a strong research background to support why they do what they do. It's almost as if it gets taught from generation to generation, and then it becomes dogma. And so I challenge this minimum of 4 per year on a number of levels. The other thing is that my patients, their pain returned after 2 to 4 weeks after the injection. So what were they to do? Wait 2 months? What were they to do with their pain? Just stay at bed rest? How could they be gainfully employed? And so this also was what prompted me to lighten the dose. You notice I'm using a lower dose of Marcaine. I'm not giving a tremendous dose of steroids, and I'm diluting it all with Serapin, the anti-inflammatory from the Pitcher plant. And so I would estimate that the average patient who was on a knee injection schedule in our practice came in every 4 weeks. And I can tell you that, again, after over 26 years of doing this, I never had a patient who had an adverse effect from this. All the patients received reduction. All the patients reported no side effects, no allergic reactions. We never had an injection-associated infection. And on average, I saw about 30 people per day. Now, that doesn't mean that all 30 of them got knee injections. Probably 1 or 2 or 3 a day would be getting knee injections. I want to remind you, by the way, as I do in all of my monographs, that this monograph is intended for information only and not as medical advice. Every patient receiving a knee injection must have a thorough history and physical performed by a licensed medical practitioner. So there you have it. Here's my final comments that I've carefully enumerated for you what I think is the best way to perform a knee injection. The way that I've taught you today is nearly painless, results in very few side effects, has an incredibly positive result for the patient's reduction in terms of reduction in pain, and can be repeated every 4 weeks without any major difficulties. I hope you've enjoyed this video monograph of my published monograph on chronic pain relief options, the best knee injections. This is Dr. Jeffrey C. Beto, and it's been my privilege to meet with you today, and I thank you very much for listening. If you have any questions whatsoever or any comments about my technique or any disagreement even, feel free to contact me at chronicpainreliefoptions.com. You can send me an email, and I will be sure to get back to you within 24 hours. Thank you very much for your kind attention. Wishing you or whoever may use this technique to see much healing and get much joy from seeing their patients get relief.